Okay, guys, let's get started so we can get done. Okay, guys. I can't get my iPad to connect, so I'm gonna record tonight what I wanted to go over with the graphs. So I'll give you a separate video tonight. I'll post it with the graphs on those pages because it's important that puts everything together, explains it all. So we're going to continue on, but I'll get those drawings in there for you, and we'll review it definitely on Monday. So what determines what our systolic blood pressure is? The top number in our blood pressure measurement. So we know that mean arterial pressure is proportional to cardiac output and systemic vascular resistance. That's what SVR means. What is the resistance in the system, in the body? If MAP goes up, systolic blood pressure is going to go up as well. If cardiac output goes up, systolic blood pressure goes up. If your systemic vascular resistance, all the resistance in the arteries goes up, your blood pressure goes up. Why? What do we learn about resistance on Monday? What are the two factors that determine resistance to flow? The length of the tube and the diameter, the radius. So total peripheral resistance, I'm increasing the constriction of the vessels. If the increased resistance in the vessels, the diameter gets smaller, the pressure goes up. That's what's increasing systemic vascular resistance. Stroke volume. Any increases in stroke volume will increase systemic vascular resistance and your systolic blood pressure. More blood is leaving the heart, more pressure. Keep in mind, wherever there is volume of blood, there's going to be pressure there as well. The more blood, the more pressure. The more blood leaving the heart, the more pressure there is in the system, because more blood is leaving. That's why if you have hypovolemia, you cut your femoral artery and blood squirting everywhere. That hypovolemia is reduced blood volume. What's going to happen to that patient's pressure? It's going to drop because there's no blood left to cause the pressure to go up. Aortic compliance. We talked about the aorta being that compliance, that high pressure reservoir, that when that big bolus of blood leaves the heart, the aorta bulges to accommodate all that blood, but it's also very muscular, so there's a recoil that happens with the aorta. That recoil pushes the blood, gives it a little boost of blood to the whole body, so it gives a little bit of higher pressure. If you reduce the compliance in the aorta, it's not going to expand to accommodate that blood. The same compliance we learned about the left ventricle. If I reduce the compliance of the aorta, what's going to happen to the pressure? It goes up. Smaller changes in volume, normal changes in pressure, but now we're losing the compliance. So that same volume of blood now is going to exert a higher amount of pressure, raising systolic blood pressure if you lose aortic compliance. Make sense? Yes? Okay. So that loss of tissue elasticity in the aortic walls, atherosclerotic changes in the arterial walls make the aorta stiff. The aorta is like a garden hose. It's very pliable, but over time, as you get older, it will get a little harder. Calcification, old age, that's why blood pressure usually goes up a little bit as you get older, because the aorta loses a little bit of compliance as well. Your diastolic blood pressure will also alter your systole, your systolic blood pressure. The higher your diastolic pressure is, if you're already at a higher pressure at rest during diastole, when you squeeze, it's going to have a higher systolic pressure as well. So whatever your baseline blood pressure, diastolic blood pressure, was going to alter your systolic blood pressure as well. So these are the factors that will alter your systolic blood pressure. Determinants of diastolic blood pressure. What can alter your diastolic blood pressure? That's the bottom number. One is vascular resistance. High arteriolar resistance, vasoconstriction. We're reducing the diameter or the radius of the vessel. The resistance, the pressure goes up. So your diastolic pressure is going to go up. Runoff of blood from the aorta. We said before, when that aorta recoils, the majority of the blood leaves the aorta and goes to the body. Then I said a little bit of it comes back, hits the aortic valve, causing that dicrotic notch to occur. In some cases, like in aortic insufficiency or aortic regurgitation, the aortic valve doesn't close properly. So when that blood is in the aorta, gets aortic compliance, so the recoil occurs. When that blood goes back, it should hit the aorta and then bounce aortic valve and then go to the system. But because that valve is incompetent, it's leaky, some of that blood goes back into the ventricle. So how much is my normal stroke volume? 70 mLs. So all 70 should go to the body. That provides your diastolic pressure. In this case, with runoff of the blood from the aorta, not all 70 mLs goes to the body. Maybe only 55 mLs go to the body, 15 mL go back into the ventricle. You're reducing the amount of blood leaving the heart, therefore the pressure comes down. So that's where you're altering your diastolic blood pressure because there's less blood leaving the heart, less blood in the system at rest because nothing's there. Some of it went into the ventricle, some of it went to the body. That's the runoff from the aorta. That will decrease your diastolic blood pressure. Diastolic time interval. What is happening during diastole? Filling. We're filling with blood. So the faster the heart rate, the higher the diastolic blood pressure. So when you start exercising, your blood pressure goes up. Why? Your heart's squeezing harder, more blood going into the system, therefore higher blood pressures because there's more blood going out. So faster heart rates increase diastolic blood pressure. Slow heart rates reduce diastolic blood pressure. There's a less time for a decline in that aortic pressure because the heart rates are happening so fast, the aortic pressure can't come down, which is your diastolic pressure during rest. It just keeps staying up because the heart is constantly pumping out more and more blood at a faster rate than normal. So that goes up as well. So how do we regulate our systemic vascular resistance, SVR? It is also interchangeable with another one that you may see called total peripheral resistance. The total peripheral resistance will also include the veins, whereas systemic vascular resistance is only on the systemic side, so it's just really the systemic circulation, not the pulmonary. Because pulmonary vascular resistance we'll deal with next week when we talk about the lungs. So systemic vascular resistance, what's going on in the body? Okay, also known as total peripheral resistance, mainly determined by diameter of those arterioles. That's where a lot of the resistance occurs of our vessels. The diameter changes, the radius changes in the arterioles. Vascular tone. Normally, we do have some tone to our vessels. They are slightly constricted all the time. That allows our pressure to stay where it's supposed to be. If we had total collapse of our vessels and they went wide open, there was no tone to them, what do you think would happen to your blood pressure? It would drop. Okay, because we don't have the volume to fill in that extra space. So the arterioles are the sites of active regulation of blood flow. Just remember that. Anytime you give a drug for blood pressure that's going to attack these vessels, it's going to happen at the arterioles. That's where it occurs. What affects arteriolar tone? Sympathetic tone, okay, fight or flight. Hormones, endothelial, and some metabolic factors as well. And systemic vascular resistance is increased with vasoconstriction. Makes sense, we're constricting all of our vessels. Resistance should go up. And obviously it's going to be decreased when you vasodilate. When those vessels open up and expand, the pressure goes down. Go back to your Ohm's law with the resistance, the length of the tube and the diameter of the vessel. Okay, venous return. The cardiovascular system is a closed system, so whatever leaves the heart, the same amount of blood has to come back into the heart. Okay, we're closed unless we had an opening somewhere where we're losing blood. Normally, whatever your cardiac output that's leaving the heart should equal the venous return, whatever's coming back into the heart. So venous return is the amount of blood coming back to the heart per minute, liters per minute, just like cardiac output. Venous return, they're coming back. We measure central venous pressure, and that's the pressure of the venous blood, mainly in the thoracic vena cava and the right atrium. This is where different catheters come in with like ICU patients. You can't measure venous pressure unless you have a catheter on the venous side, on the right side of the heart. So that's why central lines, they go into the jugular, because they can go right down the superior vena cava, right into the right atrium, and now we can start measuring what your central venous pressure is. What's the pressure in the venous system? Why is it important to know what the pressure is in the right atrium? What 2 points determine flow through our entire systemic system? The pressure generated by what chamber? Which ventricle? Left ventricle. We look at that number, which is around 120. The flow goes through the entire body, but it has to come back to the right atrium. So that right atrial pressure is very important. That tells you how far apart you are. As your venous pressure starts creeping up, those two numbers come closer together. What's going to happen to flow? Is it going to increase or decrease when these numbers come together? Decrease, because remember your potential from high to low. High pressure in the left ventricle, low pressure in the right atrium. That pressure gradient is what drives the flow of blood through the entire systemic circulation. 120 to like 5. 5 is normally what your normal central venous pressure is, 5 millimeters of mercury. So 120 to 5, that provides the gradient for flow to occur. If you're at 120, now that central venous pressure goes to 10, we've reduced that gradient, flow will be reduced as well. That's why it's important to know what right atrial pressure is. It tells us what central venous pressure is. Make sure we have a nice gradient for flow to occur. So a low central venous pressure will promote venous return. Okay, wide gradient is going to promote flow. High central venous pressure reduces venous return. So central venous pressure has a very strong influence on cardiac preload. And if you alter cardiac preload, you're going to alter stroke volume, which then in turn is going to alter what? Cardiac output. Always work so you end at cardiac output. So if you have a patient who has a high central venous pressure, we're going to reduce our venous return. Less blood is coming back to the heart, right? If less blood is coming back to the heart, what happens to our end diastolic volume? Decreases. Less blood is coming back to the heart. Therefore, our end diastolic volume has to go down. Less blood's coming in, less end diastolic volume. End diastolic volume goes down, what happens to your preload? Goes down. If my preload goes down, what happens to my stroke volume? Goes down. My stroke volume goes down. What happens to my cardiac output? Goes down. That's why you don't want high central venous pressure. You see how you walk yourself all the way through to get the cardiac output. Okay, that's it for this one for now. So, altering venous return. Okay, you guys do blood pressure. You do it sitting and standing, right? Why do you do that? We want to see how your body responds when you stand up. You're going to alter your venous return by changing positions. Change in posture from supine to standing causes initial decrease in central venous pressure because gravity is pulling all that blood down. So at first there's a little dip in it. And also we have all your blood right now is in your legs. So when you go to stand up real fast, there's not enough time for that blood to rush back to the heart. So at first there's an initial decrease. But our body in a normal, healthy person, you don't feel it because instantaneously we have receptors that kick in to get your heart rate back up again. And you don't feel dizzy. The people who don't have the right mechanisms in place or they're altered, when they stand up, they're going to get dizzy and lightheaded because the blood is not there anymore. So if you decrease venous return, decreases cardiac output and decreases your systemic arterial pressure. Less blood leaving the heart, less volume of blood, less pressure. So the BP is going to return to normal due to our baroreceptor reflexes. The word baro refers to what? Pressure. Barometric pressures with air and all that stuff. You can get barotrauma, people who go scuba diving, due to the pressure changes, they can have pressure trauma, barotrauma. So our baroreceptor reflexes are there to sense when we have low pressure, hey, we need to kick in a little bit of sympathetic nervous system, kick in your heart rate, a little contractility, and get your cardiac output back to normal. Rhythmic contraction of skeletal muscle also promotes venous return. Okay? If you ever watch people at parade, the military parades, they stand at attention for hours. Sometimes you'll see people just pass out and fall because they're not moving their calves. They're supposed to stand there and wiggle their toes. You can't tell that someone's wiggling their toes when they're standing there, but wiggling their toes provides enough of a skeletal muscle pump to get their calves working, to get the blood, at least some circulation going. When they stand there at attention all the time with knocked knees, the blood just pools in their veins, not enough in the system, and they pass out. Just so you know, when you pass out, that is your body's self-defense mechanism. So when you're upright, you're going against gravity to get blood to the brain. When your brain doesn't have enough blood, you're going to pass out. Why do you pass out? So then you go flat. And there's no more gravity anymore, so that's why everything evens out. If you ever feel like you're going to get dizzy, lightheaded, you're going to pass out, don't try and walk to a bed, you won't make it. Just sit down where you are if it's safe. Just sit down, put your legs up, and you'll be fine. What happens if people try and walk to somewhere? They don't make it, they pass out, hit their face on a sink or whatever, and now you went from just a simple syncopal episode to now facial reconstructive surgery, a bunch of other things going on because of that. So just make it. Rate and depth of your ventilation. Forceful inspiration causes your intrathoracic pressure to decrease. We mentioned that before with our physiological split of S2. When you breathe in, your intrathoracic pressure decreases. Air is compressible, so the more air you put in, the decreased pressure happens. We don't increase the pressure in your lungs. You wouldn't be able to breathe if that happened, right? Because everything goes from high to low. As you breathe in, if the pressure in my lungs went up, I couldn't get any more air in. So when you breathe in, having the pressure decrease allows more air to get in. That's why breathing is passive at rest. You don't need to think about it. It just happens. It goes from high pressure outside to low pressure in your lungs, and then air goes in. When that happens, external force on the vena cava and the right atrium distend because nothing's pressure to keeping it stuck down because the lungs went away. Venous return that provides like that suction, and blood just rushes back into the right side of the heart. Again, deep inspiration is increasing my venous return. How do I alter venous return? That's all I'm worrying about is how much blood comes back to the heart. I'm not worrying about afterload, not worrying about contractility. Those are heart properties. We're dealing with the vessels. So how do we alter the blood coming back to the heart? Skeletal pump, inspiration, change in your posture. Those are ways to alter venous return. Transmural pressure, and this is going to explain a little bit why when you breathe in deep, it causes stuff to, like a suction. Transmural pressure is extended across the wall of a structure. So, with deep inspiration, the transmural pressure across the wall, so this is during quiet expiration, here's deep inspiration. Do you see how this vessel popped open and how much bigger it got? Because we decreased the intrathoracic pressure from here to here. Deep inspiration, reducing intrathoracic pressure, reduces the transmural pressure holding down on top of the atria, the pressure across the wall. What pressure is keeping the vessel open? You learned that one too. Hydrostatic pressure. Hydrostatic pressure pops the vessels open. Transmural pressure is the external pressure pushing against the wall. So, with the right atrium, when you breathe in deep, the external pressure outside the heart exerted by the lungs and the intrathoracic pressure goes away. So we reduce the transmural pressure. The right atrium pops open, much bigger, and like a suction, just pulls venous return right back in. So this is what transmural pressure is. Hydrostatic pressure is keeping it open. Transmural is pushing it down. Okay, cardiac and systemic vascular function curve. So in a closed system, we know whatever leaves the heart has to come back to the heart. And if you increase the return to the heart, then what's going to have to happen on the other end? Cardiac output. It's going to go up as well. So they affect each other, but they're not totally related. They're kind of like two ends of the spectrum. If you alter the cardiac output going out one way, eventually that blood's going to have to come back. So the flow through the system depends on our cardiac function, what the heart is doing, and our vascular function, what's the vessels doing. So factors such as cardiac excitation, what's the vigor of the heart, how hard is it going to squeeze? Blood volume, how much blood's in the area, how much blood are we moving? Vascular compliance, resistance, all those things are going to influence our blood flow. So, venous return versus right atrial pressure. Here is our venous return. As our venous return goes up, we have more blood, right? That's what we're talking about. High amounts of blood, low pressure in the right atrium pressure. As the pressure comes down, right atrial pressure goes up because more blood is able to get into the right atrium. Okay, high venous return, this is what? This is the flow coming back. Right atrial pressure goes up, the lower the venous return is. The pressure is there. Remember, we want to favor the return. The flow coming back into the heart is determined by that right atrial pressure. The higher the right atrial pressure, the less venous return happens because there's higher pressure in the right atrium. That's altering our pressure gradient from the left ventricle to the right atrium. Yes?
Oh, okay. So the high amount of blood is in the veins, so it's going to have less pressure in the atrium?
So think about it the opposite way. I'll explain it the other way I explained it. As you increase right atrial pressure, you're decreasing the gradient between the left ventricle and the right atrium. When you decrease that gradient, you're decreasing the return back into the heart. Because that gradient is now smaller than it was before. We're increasing right atrial pressure, which is also known as central venous pressure, the pressure in the right atrium. This is just the amount of blood coming back into the heart. That's all this is telling you. As you increase right atrial pressure, less blood can come back in because we've altered the gradient for flow. From 120 to 5, now we're at 120 to 10. We've altered that flow, so venous return has to slow down the higher the right atrial pressure is. So if you increase blood volume or you decrease venous compliance, how does decreasing venous compliance alter your right atrial pressure? Increases, right? All that venous compliance goes down. That means the blood's leaving the veins. It's going back into the heart. So we're increasing venous return. That's why if you increase blood volume, decrease venous compliance, this whole thing shifts to the right. If you reduce blood volume or increase venous compliance, the amount of blood the veins are going to hold on to, this curve shifts down to the left. Okay, so just remember how you alter things, what's going to happen. Now we're talking about vasodilation and vasoconstriction. If I vasoconstrict, less blood is going to come back because I've reduced the radius of the vessels. So as you alter the diameter of the vessels, it's only going to alter the venous return. It has nothing to do on right atrial pressure. That's why all those points go to one area on the bottom. But they're altered. If you vasodilate, more blood can get through, therefore venous return goes up. If you constrict your vessels, less blood can get through the system because we reduce the radius. Therefore less blood, and therefore less return. Okay, so all we're worrying about now is how we can alter venous return. Here's our Frank-Starling relationship again, the contractility curve. Obviously we know increase in right atrial pressure drives more ventricular filling. So if we get more blood coming in the right atrium, more blood is going to be in the left ventricle. More blood in the left ventricle at end diastolic volume is going to increase what? More blood, end diastolic volume, preload, increase your preload. But we also said the more blood in the heart stretches. And what happens when that heart stretches? More forceful contraction. But in between that point, what is special about when the heart starts to stretch? What does it become more sensitive to? Calcium. So the bigger the stretch, the more sensitive to calcium we are, therefore the greater the contraction can be. That's why if you increase end diastolic volume, the contractility is also going to be improved as well. Now, if you take our cardiac output contractility curve, the Frank-Starling line, and you take the other line we just went over, the venous return over right atrial pressure, and you plot them on the same graph, obviously, let's look at just the cardiac output, just the black one. As you increase right atrial pressure, what's happening to the volume of blood as you increase right atrial pressure? Increases. We're increasing the pressure, increasing the volume of blood. More blood in the right atrium, cardiac output has to go up too. Make sense? More blood coming back into the heart, more blood leaving the heart, therefore the contractility is going to go up as well. Venous return. We've also talked, as right atrial pressure starts to go up, venous return goes down because our flow gradient is reduced. So flow goes down. When you put them both on the same line, wherever they cross, it's called your operational set point. And if you were to draw a line, if this was labeled, When we are at rest, what number should be right here? What's our normal cardiac output or a normal venous return? 5. Stroke volume is 70. Cardiac output is 5 liters per minute. And that will be right there at 5 liters per minute, which means whatever's leaving the heart is coming back into the heart. If you change any of these variables we talked about before, blood volume, venoconstriction, vasoconstriction, it's going to alter this set point. And that tells you where your venous return and cardiac output are going to match up as you alter these things. And I'll do it in my recording later when I draw it out for you guys. It'll make more sense. Do you have a question?
Yeah, so why does it matter when they match up?
Because we have to know everything what's leaving the heart has to come back. So where the lines cross, that is the point that we're going to be at. That means that whatever's leaving matches whatever comes back in. That's all. So here's an example. Dynamic exercise. When you start exercising, cardiac output has to go up. Okay, we're increasing our ventricular contractility. Therefore, our contractility line gets shifted up to the left. Venoconstriction also occurs during exercise. So if venoconstriction is occurring, what happens to our venous return? Increases as well. Venoconstriction, we're squeezing the veins. Blood only has one way to go. Why does blood only go one direction in veins? You have the valves there. So it only goes one direction. So with exercise, our contractility goes up. Our venous return goes up. Now we're at a new set point. And this can be like 8 liters per minute, which makes sense. You're exercising. You need more blood to go to the entire body. And whatever blood leaves the heart has to come back. That's why these two lines, we look at where they cross, and that will tell you what your liters per minute should be. And they always need a match. Because if they don't, that means we have a hole somewhere and blood's leaking out somewhere. So that whatever leaves should come back. So with exercise, our cardiac output goes up because our heart's squeezing harder. Venous return goes up because our veins are constricting. And we also have decreased systemic resistance. So our vessels are wide open. And yes?
Don't we vasodilate because our heart rate increases when we exercise?
So this is talking about venoconstriction. So remember, I mentioned always look at the words. So veno is talking about just the veins. So the veins are going to constrict to push the blood back up.
But our vessels.
So the vessels we'll get to in a little bit in this lecture. When we talk about shunting of blood, when you're exercising, what actually happens is you shunt blood. But through what part of the vessels is the biggest site of resistance? The arterioles. So in the next section we'll get to all different parts of our body can be sectioned off. And during exercise, do we need any blood going into our GI system? No. So when you're exercising, we shunt the blood away from the GI system and it goes to our muscles where the blood is needed. So there's a little different there with what happens to your resistance there. We'll get to that later. Okay. So we talked about the cardiac cycle, mechanical events, electrical events, excitation, contraction, coupling. We took the cardiac cycle, we mapped it out with heart sounds, volume, we did our pressure volume curves. We talked about cardiac output. We talked about how we can alter a cardiac output through stroke volume, preload, afterload, contractility. We talked about how cardiac output must match venous return. Whatever's leaving has to come back. How do we alter those things? Now we're going to get to how nerves and hormones have a role in regulating our heart rate and blood pressure. So again, our main homeostatic variable is always going to be cardiac output. How much blood is leaving the heart? Wall stretch is determined at strategic locations in our system to provide information about our blood pressure. we don't know what our blood pressure is, but our body has to know what's going on with our system. So we have different receptors to look at wall stretch. If the walls are being really stretched, then we know we're fluid overloaded. We have too much volume in the system, stretching all of our vessels. We have a carotid sinus baroreceptor, which gives momentary feedback about arterial blood pressure. Okay, they're in your carotids. Okay, that's why you don't check pressures on both sides, because then you'll pass out. Because what you're doing, if you start rubbing your carotid, if I'm stimulating that baroreceptor, what does my brain think? That I have high pressure or low pressure? High pressure. Okay, so if I release it, then there really is no pressure anymore. And so the body wants to decrease pressure if I do this, right? The body thinks, oh, we have high pressure. We need to do something to relax you and calm you down. So your vessels dilate. But then you remove it, and then pressure goes too low, and you pass out. So only do one, you don't do both. Some people have very, very sensitive carotids where they can't, like for men, they can't even wear ties because just the pressure of the tie will stimulate the carotid baroreceptor and they just pass out. So we talked about orthostatic, like hypotension, changes in position. And we said, well, we have baroreceptors throughout our body. Well, the carotid is one of them. And they're going to sense that pressure drop and they're going to kick in. And we'll talk about what they do actually in a minute. The renal juxtaglomerular apparatus. Obviously, it's in the kidneys. And they sense circulating blood volume. Okay, so kidneys sense blood volume, which is a indicator of pressure, right? The more volume of blood you have, the higher the pressure. So the kidneys will sense effective circulating blood volume. If the blood volume goes down and the kidneys sense it, they're going to kick in that whole renin-angiotensin cascade, which we'll get to a lot more detail later, to raise your pressure back up. So the kidneys sense circulating blood volume. We also have low pressure baroreceptors. They're mainly in our venous system, and the cardiac atria provide information about blood volume as well. So we have receptors in our ventricles and our atria, and when you are fluid overloaded, like when you have congestive heart failure, there's too much volume in the system, so the heart starts to stretch. And as that heart stretches, it's sensed by these things, and it starts releasing your natriuretic peptides. If you ever heard of BNP, there's another one called ANP, which is atrial natriuretic peptide. That's where we're going to get to here. So we're going to go through these in detail to discuss them. So I bring this back because this is the one I told you on the very, very first lecture of all the different things that go into just monitoring your blood pressure. So now we're going to start going through some of those things as far as regulating blood pressure. So renin-angiotensin, here's your atrial natriuretic peptide, and vasopressin. So our autonomic nervous system obviously plays a very, very big role. Primary site of cardiovascular control is within the CNS in the medulla oblongata, so in the brainstem, which is why I said if someone has a stroke and they can't support their heart rate, blood pressure, or breathing, that's in the brainstem, and that's usually a very, very poor prognosis. We have inhibitory neurons, excitatory neurons that go into the parasympathetic. Why would it make sense for the inhibitory ones to affect the sympathetic nervous system? What does it provide? And conversely, why is it important the excitatory ones hit the parasympathetic one? Counteract. We don't want the sympathetic system to be stimulated and no way to control it and shut it off. So by having inhibitory, it provides a way to shut down the sympathetic nervous system stimulation. So inhibitory neurons will shut down the sympathetic. It provides control from going too extraneous with heart rates and blood pressures. The excitatory neurons on the parasympathetic ones, again, it's control. Parasympathetic is to calm things down. So having a very high excitatory parasympathetic is just going to calm your heart rate down and your blood pressure down. So excitatory gets that going so we can calm your heart rate down, and the inhibitory one also provides control to calm things down. And we have these basal baroreceptor inputs, results in tonic activation of the parasympathetic outflow, so we're increasing the stimulatory part of the parasympathetic, and suppression of sympathetic outflow. We don't want the sympathetic system working all the time. That's that underlying stress that's happening all the time at your sympathetic nervous system being active. So we want that to be calm. Parasympathetic needs to be in control. So the parasympathetic through our vagus nerve, right? Isn't the vagus nerve one of the parasympathetic ones? Okay, there's only a few of them. It innervates the SA node and the AV node and the conduction pathways and the cardiac myocyte. So we have a very deep parasympathetic innervation in the heart via the vagus nerve. And the effects slow heart rate, slow the conduction through the heart, all to lower the heart rate, lower the blood pressure. And that's the role of parasympathetic. The sympathetic system, that's the excitatory, fight or flight. Beta 1 receptors in the heart, when you activate them, are going to increase the heart rate, increase conduction velocity, and increase contractility. So the heart's going to squeeze harder, it's going to squeeze faster. When that happens, what happens to your cardiac output? Increases, it goes up. Think fight or flight. If the sympathetic system's working, we're running away from a bear, you need a lot of blood to do all that, your cardiac output better go up. We have alpha 1 receptors. The alpha 1 receptors are mainly in the vascular smooth muscle. In which type of vessel? What is the site of greatest vascular resistance? Arterioles. So when we say these alpha 1 receptors, it's at the arterioles that's doing it. So the alpha 1 receptors generalize vaso and venoconstriction. So remember I said before, when you are in a fight or flight response or you're exercising, we don't want blood going to unnecessary places. So what neurotransmitter or hormone is going to attach itself to these alpha 1 receptors? Norepinephrine. Epinephrine does it a little bit, but mainly norepinephrine in this one. Remember, these are adrenergic receptors. Sympathetic nervous system. Fight or flight. Epi, norepi. All go together. Start thinking, putting these things all together all the time. So it's going to shunt the blood to areas that we need. And during a sympathetic response, where do we need that blood? Muscle. So we have beta 2 receptors also in the vascular beds as well. But they're mainly in the skeletal muscle beds. And they provide vasodilation. Does that make sense? You want the blood to go into the muscles. So you need to dilate those vessels. That's why people who do weight training get that muscle pump right afterwards. They get bigger because they're working out their muscles. Blood's engorging the muscle, makes them look bigger. So these beta 2 receptors are found in the vascular beds, skeletal muscle, and they help with vasodilation so that the norepinephrine through alpha 1 stimulation is going to shut off the blood to the GI system, to other parts of the body we don't need. And the epinephrine is going to hit those beta 2 receptors and open up the vascular beds in the skeletal muscle so that the blood is going to shunt to the skeletal muscle. The same thing happens like when you're very cold and you start freezing and shivering. We have to move the blood away from our extremities to our core. The way you do that, you block the alpha 1 receptors and you start shunting blood. Well, we don't do it, our body does it for us. and the blood goes away from the extremities and it goes into our core. You have to stop blood from getting to certain areas. Alpha-1 receptors do that. They cause the vasoconstriction, and they will help with that. Norepinephrine has a very high affinity for alpha receptors. Okay? So these alpha receptors is going to be norepinephrine. The beta-2 is going to be epinephrine. So the net effect of sympathetic nerve stimulation is vasoconstriction, because we're constricting a lot of our vessels, and it's going to raise our systemic vascular resistance. If our systemic vascular resistance goes up, what happens to our afterload? Increases the afterload. If you increase the afterload, and this is we didn't go over much detail before, which I wanted to, but I can't draw it out. If you increase the afterload, what happens to the stroke volume, do you think? It's going to increase or decrease? So it's going to decrease it. So remember, we talked about the cardiac cycle. If your heart rate is 60 beats per minute, that means you got 1 second to complete the entire thing. Okay? Open up a regular door. You can open up pretty fast. Now you go to the door out there in the front. Okay? Think of the time it takes you to open that door open. Now it takes you a little bit to generate the pressure to open that door. It's slower. Everything still is going to happen in that 1 second. If you're spending more time in isovolumic contraction because you got to generate more pressure, you have less time to squeeze all the blood out. If you have less time to squeeze the blood out, your stroke volume goes down. That's why afterload is the only one that's opposite. If you increase the afterload, you will decrease the stroke volume. If you decrease the stroke volume, what happens to cardiac output? Decreases. So let's go another step. My blood pressure was 120, now my blood pressure is 180. What happened to my systemic vascular resistance? Did it go up or down? It went up. So systemic vascular resistance went up because my blood pressure went to 180. What's going to happen to my afterload? It increased. I have to generate more pressure to overcome the aortic pressure set by our blood pressure. So if my afterload goes up, I have less time to squeeze, therefore less blood comes out. So if you increase afterload, you decrease the stroke volume, which is going to decrease your cardiac output. Contractility and preload are both positive correlations. If you increase preload, you increase contractility, your stroke volume goes up. Because preload, you have more blood coming in the heart, so obviously more blood will leave stroke volume. So that make more sense now with these afterloads, preloads, contractility. Put them all together, always try and end up at cardiac output. Okay, so mentioned this already. We get catecholamines from the adrenal medulla. The catecholamines are, and we'll finish in a second here, epi and norepi. Epi will have a higher affinity for those beta-2s, those skeletal muscle beds. Yeah, we'll stop here at this last one. Baroreceptor reflex. So changes in our systemic arterial blood pressure. Oh, PA students, forgot to tell you guys. Tomorrow's history taking was canceled, so you have morning off. But the advanced summer team classes are going to be in 314 tomorrow morning. So 314 will not be available to study. The other class is going to be in there, but 12:30, it's your room again. So primary receptor in the carotid sinus. We also have one in the aortic arch. So in the aorta and the carotid, we have baroreceptors there. Carotid massage, IV bolus can also help terminate certain abnormal heart rhythms. And this graph just kind of talks about you have your carotid sinus receptor. Here's your aortic arches. They send a signal that decreased MAP from when you stand up, your pressure drops a little bit. baroreceptor firing, increase sympathetic tone, decrease parasympathetic tone to increase SVR, increase stroke volume, increase heart rate, increase vasoconstriction so that you don't have dizziness. That's what all these things do for the, so you have to know this baroreceptor reflex, how it works. We'll finish up the last little bit on Monday. I will post the recording with the drawings to make everything make more sense with regards to everything else.